Thank you for your introduction. It's a pleasure to be here and to bring you this work from our university. I will start with an introduction to patient safety with a Latin axiom, primum non nocere. Basically, we should start by do no harm to the patient when we work. And I should define patient as the recipient of our work, our healthcare provided. Patient safety can be regarded as the reduction of risk of unnecessary harm associated with healthcare to an acceptable minimum. And as any other culture, safety culture is a set of principles, attitudes, perceptions, competences, or standards that are shared by a community, in this case by radiographers. I put this definition here. You can look that it comes from another industry outside the healthcare. It comes from nuclear installations. Also, the aircraft industry regards safety as a priority, or the nuclear installations as a priority. So healthcare must look at this as a priority. And to do no harm, we must know what harm is, and we define the adverse events as unintended injuries or complications that are caused by healthcare. So not the underlying disease of the patient. It's our work that causes the harm to the patient. And I will end this introduction with why errors happen, and I have another Latin axiom, errare humanus est, basically where humans work, errors will happen, we must lower them as much as possible. The purpose of our studies was to check if a translated version of the hospital survey on patient safety culture could be applied in our radiographers' population, to assess the radiographers' safety culture, and we also wanted to check if gender, age, and professional experience has an effect on the perception of the professional about the patient safety culture. This was a cross-sectional study, and 67 radiographers accepted to participate. The variables measured were the perception of patient safety, with the 42 items of this questionnaire, and grouped by the 12 dimensions, and 2 single items that were frequency of events reporting and patient safety grade. We got high internal consistency, measured by the Cronbach's alpha. Most of the respondents were female, and in Portugal we have, after the bachelor's, we have one more year of study, and most of the respondents had that more year of study. And the majority works for 15 years or less in radiology. Regarding the internal context of the radiology department, so our direct colleagues, we had these dimensions, teamwork within units, that accounted with 87% of positive responses. The supervision actions accounted with 70%. Organizational learning accounted with 63%. Feedback and communication about error accounted with 33% of positive answers. Communication openness accounted with 43% of positive answers. Staffing was the lowest one, and the non-positive response to errors was also low. The external context, or the others that interact with the radiology department, about the perception of the radiographers about the others that interact with the radiology department, were evaluated by these 3 dimensions. The management support, and it accounted with only 18% of positive answers. The teamwork across units was about 57%, and the end-offs and transitions was about 61%. About result dimensions, with these 2 dimensions, overall perceptions about patient safety was 75%, which starts to be good, and the frequency of events reported was below 50%, so 43%. The patient safety grade was acceptable or very good. Only 3% stated that it was excellent, and the number of events reporting, the majority never reported any errors, so this is a major concern, because for sure they made errors, but they are afraid to speak up. About the effect of gender, we used the Mann-Whitney test, and women presented better results in these dimensions, and men only in one dimension presented a better result that was significant, that was the patient safety grade. So men think that the patient safety grade in the radiology department was better than women. About the influence of age in the perception of the professional, we got 3 dimensions that were significant: dimension 5, dimension 8, and dimension 12. And about the professional experience, we got also 2 dimensions that were significant: dimension 5 and dimension 8. There is a mistake that I just noticed. Sorry for that. This is about the professional experience. So, in conclusion, and quickly, the psychometric properties of the usage survey need further investigations to check if this is an effective tool to measure the reality of our department, of our radiographers population. There are areas that clearly needs urgent intervention, and of course improving safety is very important so that we can have safer health care and do not harm patients. That is a nonsense, but we do it almost every day and sometimes without notice. These are some references that can be read. This is my personal contact. Thank you for your attention.